This hearing of the Military Construction, Veterans Affairs, and Related Agencies Appropriations Subcommittee is now called to order. Today, we're going to be discussing the Department of Veterans Affairs FY22 budget and the FY23 Advanced Appropriations requests. Veterans deserve more than just words of gratitude for their sacrifice when they return home. They deserve the quality care and benefits that they've earned. This budget strives to do that and requests a mandatory appropriation of $153 billion and a discretionary appropriation of $113 billion. That's an 8.2% increase over FY21. It also requests $156 billion mandatory advanced appropriation as well as $111 billion discretionary advanced appropriation just to support its medical programs in FY23. The cost of medical care continues to grow, and there are a lot of issues that we want to discuss this morning. We understand that VA's budget request is a bit complicated this year. The department's request reflects the direct and indirect costs of the pandemic, including addressing the increases in the disability claims backlog, as well as the provision of deferred care and increased mental health services. Funding provided in the Families First Act, the CARES Act, and the American Rescue Plan demonstrate congressional support for veterans during this challenging time. And much of the funding remains available for use in fiscal year 2022. In addition, this is the first year VA is allowed to use flexibility provided by Congress in the Recurring Expenses Transformational Fund, and VA plans to use $820 million of expired funds to support information technology and minor construction projects. While this is a robust request, especially considering all of the additional funding recently provided to the department, VA must have what is necessary to respond to veteran demand. VA's request for FY23 shows a decrease in this program without supplemental funding. I hope that the need has subsided by then, but VA must plan effectively to avoid service cliffs relative to demand in these programs. This budget was developed prior to your undertaking a strategic review of the Electronic Health Record Modernization Program. We look forward to receiving more information on the results of the review, how the findings will affect the remainder of VA's 10-year plan, and how VHA's infrastructure costs will be incorporated into the total cost of the effort. The budget reflects VA's need to invest in physical infrastructure. As veterans come back to receive care at the VA, they deserve to be treated in facilities that are up to date and modernized. This year, VA is planning to invest in its infrastructure through base funding, the Transformational Fund, and the American Rescue Plan funding. I look forward to working together to provide veterans with the services and the benefits that they have earned and deserved. And with that, I would recognize the ranking member for his opening statements.
Thank you, Mr. Chairman, and thank you, Mr. Secretary, for being here to discuss the Veterans Affairs fiscal year 2022 and 2023 budget request. The budget request of $271 billion in fiscal year 22 for the Department of Veterans Affairs, including medical care, collections, and the new Transformation Fund, representing a 10.4% increase over fiscal year 2021 enacted levels. This includes $118 billion in discretionary funds, a $10.4 billion or 9.7% increase over fiscal year 2021. The budget also requests a total of $272 billion in advanced appropriations for fiscal year 2023. The large fiscal year 2022 increase highlights the continued importance of programs for veterans. It also reflects the continued growth and popularity of the Veterans Community Care Program, which consolidated multiple community care programs through the Missions Act. In fact, in this request, the only dollars requested as part of the second bite to supplement last year's advance appropriations are for community care. Members of this subcommittee remain committed to providing VA with the resources needed to care for our veterans. VA, however, continued growth of 8, 9, and 10% gets really difficult and probably is unsustainable. Mr. Secretary, we need to work together to make certain we are prioritizing resources where they need to go, and to make sure Congress doesn't mandate costly initiatives without thoroughly considering the associated cost implications. Over the last year, VA received roughly $37 billion in emergency funding to address COVID. I have to say that overall, VA performed admirably throughout the crisis and deserves praise and recognition for that. There's no doubt that most of these funds were absolutely necessary, and the obligation reports for the CARES Act funding demonstrates this. I had the opportunity to be in a number of facilities during that time, and again, the department, all of those on the front lines, and just all of the different areas really do deserve a big pat on the back. I hope to hear more about the future needs of the VA, especially after this large influx of emergency dollars. We don't want to find ourselves in a situation where CARES and the American Rescue Plan have reset the baseline for VA spending. The budget requests $2.6 billion for electronic health modernization. Many of us on this committee have long advocated for single joint medical record that will follow a service member throughout their careers in the military and into their time as a veteran. We understand that a strategic review is nearing completion, and we look forward to hearing the new path forward for the program. In particular, we look forward to receiving a revised deployment schedule as directed in last year's omnibus. In addition to updates on those programs, we look forward to hearing details about the Department's request for mental health services, including efforts to combat opioid use disorder and prevent veteran suicide. These initiatives to prevent veterans' homelessness also are very, very important, and efforts to improve care for our rural veterans, including through the greatly expanded telehealth program, which, again, we can be so proud that the VA has been a leader. We look forward to discussing these and other issues this morning, and with that, I yield back, Mr. Chairman.
Well, I want to thank our witnesses for participating today. We have Secretary of Veterans Affairs Dennis McDonough and Assistant Secretary for Management and Chief Financial Officer John Rychalski. Did I get that right, sir? Great. Fantastic. We're going to start with questions, and I'll recognize myself for 5 minutes first and then head to the... Oh. I apologize. With that, we will go to each of you for your opening statement.
Thank you, Mr. Chairman, very much. Let me start by just offering my deep condolences to the family of Senator Warner, who will be laid to rest today. A Navy and Marine Corps vet of World War II in Korea, Secretary of the Navy, 30 years, an outstanding senator. He was a true patriot, an iconic statesman who always did what he felt was right for his constituents and for America. We'll obviously all miss him. Chairman Heinrich, Ranking Member Bozeman, Senator Schatz, and Tester, thank you for the opportunity to testify today in support of the President's FY22 and FY23 budget request and for your steadfast support for veterans. I'm accompanied today, as the Chairman just said, by our Assistant Secretary for Management and Chief Financial Officer and proud Montanan, John Rychalski. Let me also acknowledge the veteran service organizations and our union partners, all of whom make us a stronger agency. Some good news. First, we've taken steps to reduce the backlog of claims caused by the pandemic. We ramped up scanning efforts to digitize federal records for claims processing and temporarily assigned VA personnel to the National Personnel Record Center to pull records for claims processing. Now, most of VA's requests for records are answered in 2 to 3 days. The number of pending VA-related record requests has dropped by 90% to pre-pandemic levels. Second, VBA rated our 1 millionth veteran disability claim 2 weeks ago, hitting this important milestone faster than in all but 1 year in VA history, notwithstanding the challenge posed by COVID. Third, VA has now vaccinated 3.4 million people with at least 1 dose, including veterans, family members, caregivers, employees, and members of other federal agencies. Last and most importantly, on May 24th, just a month ago, there were no COVID-related deaths in any VA facility for the first time in 448 days. since March 18th, 2020. These positive outcomes are a direct result of two factors: resources, which you've been critical in providing, and caring, compassionate people. Let me tell you about one such outcome. At the height of the pandemic, Marine veteran Michael Novielli developed fatigue, aches, and a fever. He never, quote, felt this sick in his whole life, and his diagnosis was exactly what he feared. Like millions of other Americans, he had contracted COVID-19. After 4 days at Northport VA Medical Center, Michael was well enough to be discharged, but we placed him on our VA telehealth program to monitor his symptoms. That decision likely saved his life. He shared his temperature, oxygen levels, and heart rate every day for 2 weeks via telehealth. Then his VA nurse, Marjorie Rogers, noticed something unusual in his heart rate. She called him and told him to go to the emergency room immediately, where he was diagnosed with pneumonia, admitted for another 2 weeks. Marjorie saved my life, he said. If I wasn't on telehealth, I would have stayed home with pneumonia. And Michael will be the first to tell you that would have been, or could have been, disastrous. Now, that's the kind of experience every single veteran deserves at VA. VA people are the ones who cared for Michael. They are the ones who risked their lives to serve veterans during the pandemic, and they're the ones who made 0 COVID deaths on May 24th possible. But VA employees will also tell you that their life-saving work is not possible without the resources they need. That's why this budget request is critical. The FY22 budget request will ensure VA can provide care and services to veterans, their families, caregivers, and survivors, and to other Americans, such as the 488 non-veterans treated at VA facilities as pandemic-related humanitarian missions, including citizens from Arkansas, Arizona, and Texas, among others. These resources will be put to good use, empowering our department to fulfill President Biden's charter for me to fight like hell for our vets. The budget ensures we can continue the growth and success of our caregiver support program by fully integrating families and caregivers into the care plans of the veterans they love, continuing to implement Mission Act expansion of our program of comprehensive assistance to all generations of eligible veterans, and supporting the training of over 1,900 field-based staff. The budget provides needed funding for women veterans. The number of women using VA healthcare has more than tripled since 2001, and this budget funds recruiting and hiring for women's healthcare providers, improving access to reproductive health services, and emergency services. The budget allows us to continue our success in reducing veterans' homelessness, building on the success of the last decade during which we decreased veteran homelessness by 50%. And this budget allows us to provide strong, sustainable, high-quality direct care to our veterans at a time when they need it most. Community care, as Senator Bozeman said, and direct care are both important, and care in both contexts is rising dramatically as pandemic ebbs and veterans return to VA for care. And while both are growing, care in the community is rising at a faster rate than direct care. Veterans need and deserve a thriving direct care system for generations to come because it provides high-quality, evidence-based, integrated care tailored to their unique needs. Beyond that, our nation depends on the research, innovation, and medical education components of VA direct care, as well as an effective backstop to our country's healthcare system, VA's fourth mission, that has been critically important during this pandemic, as well as multiple other national disasters. That's not all these budget resources will do. They'll fund mental health and suicide prevention initiatives, address major deficits in construction, physical information technology infrastructure, continue our electronic health record modernization, address issues of veterans' environmental exposures, and continue to ensure VA is always a place where diversity, equity, and inclusion are valued and sought. In short, this proposed budget allows us to deliver high-quality whole health care and benefits to our veterans, and it does so in large part by enabling the work of great people like those who cared for Michael Novielli. I commit to using these appropriated resources responsibly and transparently in close consultation with you and getting greatest value out of every dollar. Mr. Chairman, Ranking Member Bozeman, other members of the committee, I thank you for the opportunity to appear before you today, and I look forward to your questions.
Well, I want to thank you both. And the FY22 request and the FY23 advance appropriations request, Mr. Secretary, are record levels coming on top of a record FY21 appropriation and significant supplemental funding. The pandemic provided unique challenges to projecting where veterans will demand those services. For instance, through transfers and the second bite, VA is significantly increasing resources to meet community care demand in FY22, yet this budget assumes a decrease in demand in FY23. So what is the VA's vision for the right balance between in-house and community care going into the future? And is the medical community care request in 23 the right number?
Thank you very much. Thank you very much, Chairman. We've been talking with all of you and with your teams as well as within the agency about the right balance. We are driven first and foremost by the requirement in statute that we make decisions based on best outcome for veterans. That's also the commitment I've made to the Senate in the context of my confirmation, which is every decision I'll make will be based on increasing access and improving outcomes for veterans. So first and foremost, we'll make a determination based on what is medically best for our veterans. Second, I happen to believe, and I think the data shows, that veterans in our care do better than veterans not in our care. So I think it's very important that we maintain a sustainably funded whole healthcare system in VA with the full range of specialties that our vets have demanded over time, and with care provided by providers who have particular understanding of the challenges facing vets. The fact is, however, that particularly in highly rural areas, our vets will continue to be dependent on the community as well. And this is something I've talked at length with many members of this body about, and traveled to see the impacts of our partnership with the community. And so we'll be working over the course of this year and next as we manage this bow wave of care. Our next year's advanced appropriation request recognizes that the expansion of provision of care is not, as I think Senator Bozeman fears it may be, or asks for clarity that it not be a resetting of the baseline, but it's rather an ability to manage this bow wave of care now, and then over time, as we get to post-pandemic, we'll be in a position to right-size that care in the system and find where we need to augment that care in the community.
Mr. Secretary, I know the Air Commission work is ongoing, but one of the concerns I have is that to do a market assessment during a pandemic raises a lot of questions about the data that'll go into those final decisions. We had enormous market distortions. We saw that in impacts to your budget. We saw it in the private sector. Will you provide that data to the committee, but also do you have concerns about the quality of that data?
So our teams have been looking at these market assessments now going back a couple of years. I've not dug into that data aggressively myself. I do have a belief. I do believe that it makes sense for us to relook that data in light of the pandemic, also in light of the fact that the U.S. government has just gone through the decennial census, for example, so there may be data there too for us to prosecute as we do these market assessments. So we will be augmenting the review that we've had to date. We are also committed, I've made this commitment in other public hearings that I reiterated here, to provide you that information for you to make your own decisions about this. I think it's only right that we make decisions like this with such import for the national interest in the light of public day, or in public light, and that's what we intend to do. So I'd be more than happy to make sure that we get the committee that information.
Great. I look forward to taking a look at that, and I have concerns given what a unique year it is to make very long-term impactful decisions based on data in what may be a year that is a complete anomaly. With that, we'll go to the ranking member for his questions.
Thank you, Mr. Chairman. The CARES Act and the American Rescue Plan provided VA with $37 billion to respond to the pandemic. One of the conditions in the CARES Act was that any personnel hired using this money can only be temporary employees, so as to avoid building a budget tail in years to come. And you discussed a little bit about this in your previous question, but I want to follow up. The fiscal year 2023 medical care advance appropriations request of $111.3 billion is an increase of $13.8 billion over fiscal year 22 revised request. So I guess the question is, what is driving the 14% increase? Is the budget proposing to make the temporary hires permanent? Has the sudden influx of COVID-related funding reset the VA baseline significantly higher than it was before the pandemic?
Yeah, we don't. I'll ask John to pile in on some additional specifics on this, Senator Bozeman. But we don't seek to reset the baseline. We're seeking to manage both a strong pandemic response, which the CARES allows us to do, and then ARP really allows us to sustain that response, which is going to need to be sustained through this year because of this bow wave of care, and supports recovery. But really what's happening as we see care for our veterans is a series of fairly substantial big moving pieces that include the fact that vets are living longer, that the pandemic has increased the complexity of care that our vets are facing. By the way, I think we have a better handle on that than anybody. We're doing, if you look in, you can't open a newspaper any morning now without seeing a story about VA-based research on long COVID. And to be honest with you, no other system is doing that. We are doing that thanks to your support. We have a particularly soft economy right now, and historically what we know in soft economies is that vets who are reliant on employer-provided care until now are relying on their care for us. Lastly, all those things contribute to a trend line towards complexity of care for our vets. That means that any incident of care is more complex and therefore more costly. That's coming at a time when, for example, the Mission Act has increased what we call reliance on us. So more vets are getting more services from us as a result of some of the authorities in the Mission Act. So what you see in that budget is our best assessment based on our model, and a model that's proven pretty decent over time, at what we anticipate in terms of complexity of care and reliance on us for our services from our vets. Anything you want to add, John? Did I miss anything?
Yeah, just one thing. I think when you look at our budget, there is a request, an increase in the request. But when you compare how much we plan to spend in 22, which includes ARP funding, and then you compare what we plan to spend in 23, our budget actually goes down by about $4 billion. And I think from a strategic standpoint, what you see is us hiring up and then those FTEs staying on. But we're putting most of our requests in 23 in the direct care system. And as the Secretary mentioned, we're betting that's going to be where people are going to want to get their care, and that this dramatic increase in community care is going to level off a bit. And you also see, going back to what I said, the $4 billion sort of comes, it comes down about $4 billion in 23 because we think that the community care will level off. The demand for services in the direct care system will rise. But net, we actually have a lower planned expenditure in 23 than 22 because we don't have the same supplemental funding.
So what do you all feel like is driving the increased demand for community care now? Because when you look at your modeling and you look at the numbers that you're requesting, certainly there's a bunch of community care dollars now, but not in the future. And again, don't misunderstand. Myself, the entire committee is committed to in-house specialists, quality of care, again, as good as anybody. And I think we can be very proud that the VA has achieved that. On the other hand, I think what we don't want are a bunch of surprises going down the line, which we've really seen in the last year or two.
I couldn't agree more, Senator. And I'd start on your last point, which is I don't misunderstand you, and we couldn't misunderstand you because you've been regularly supportive of all of our efforts. So we're very grateful for that. I think that what's driving community care at the moment is that by necessity, I think many providers in the community opened to full services sooner than many of our providers did. So that's one of the things that's driving this. The other is that we are experiencing now what we've been talking about for some months, which is that as the pandemic ebbs, more of our vets are coming back to address for care that they forewent during the pandemic. And that is also happening at a time when not all of our facilities are fully open. And so we do think that what is driving the care in the community are the particulars of the pandemic and less a stated desire of our veterans to get into the community. That said, partly to inform our going forward process, we're in the field right now through our Veterans Experience Office talking to veterans about what their experience in care during the pandemic was and what that says about what they expect going forward.
Good. Very good. Thank you, Mr. Chairman.
Senator Schatz.
Thank you, Chairman, Vice Chairman, Secretary, Assistant Secretary. Thank you for being here. Thank you for your service. I want to talk first about telehealth.
Yeah.
Obviously, VA's made tremendous strides in telehealth, as has the private sector, Medicare, Medicaid, DOD. It's happening everywhere. The specific question I have to start is, to what extent are any of the expansions of telehealth services dependent on or precipitated by the pandemic and likely to snap back to the Stone Ages when the pandemic is over, or are there plans in place to not only institutionalize all these expansions of services, but to expand them?
Yeah, so bottom line is that we have, let me just give you some numbers around the expansion. Basically, we estimated at about an 1,800% increase in video visits from VA to home, going from about 10,500 visits in the first week of March 2020 to 220,000 or almost 230,000 visits at the end of February of this year. So the numbers are a dramatic expansion. Another way to look at it is halfway through this year, nearly 2 million vets this fiscal year have had one or more episodes of video care through our Vets Video Connect program. So that tells us that there's massive demand. We're institutionalizing that, as you say. We want to maintain it because it is ease of access for vets who don't need to be seen in person. We see a large degree of satisfaction from our vets. In full candor, our clinicians sometimes are less excited about it than our vets, but we're working that.
Well, that's kind of what I'm trying to get at, is to what extent are any of these, at least currently, temporary changes in clinical standards or standards of care that need to be made permanent, lest we go back to where something is more comfortable for either VA docs or supervisors or fiscal people. Do we need to institutionalize some of these? Like, are there specific places we need to burrow into the to the bureaucracy or into the statutory law to make sure these things stick?
We're looking at exactly those questions. I think overwhelmingly there's going to continue to need to be things that are done in person, and we're developing those lists of what those are, working with VHA. But I think as a system, we recognize the huge efficiency gains and huge satisfaction gains, which come from the fact that vets are spending less time traveling to our facilities while getting good care. And so we have a bias toward institutionalizing, but we're going to let the data drive that too. So we'll be more than happy to stay in close touch with you on that.
Okay, I think I'll send a QFR on this
Good.
so that we can get a little bit deeper fidelity on
Fair enough.
what changes you need to make and how we can be supportive of it, because I've just seen in private pay and Medicare, there's going to be a tendency to want to snap back to pre-pandemic time, and I just think there's going to be a patient revolt. If 10 years ago, if you told someone to interact with their clinician via their iPhone, it would be an insult. And now, if you can't do that, it's an insult. And so I just think we're underestimating the extent to which people are going to freak out in 18 months if something that was fantastic and available is suddenly not. And we want to help you to make sure it's all permanent.
I agree with that, and I don't want to waste any more of your time, but I just make this point, which is we have such demand for mental health care. Like everybody else in our healthcare system at large, at such a position of competing for providers, we get a not insignificant marginal gain of access through using video platforms, that it would be foolhardy to walk away from that.
And there's at least anecdotal evidence among veterans that accessing mental health services via telemedicine can sort of overcome or circumvent the stigma.
No doubt.
And so it's all to the good. We just want to help you to make it permanent. Final question. When we spoke in January, I mentioned that veterans on Hawaii Island are still waiting for VA to break ground on the new outpatient clinic in Hilo,
Yes.
Hawaii. Can you please give me an update?
Yeah, so we have an interim lease fix in place. The permanent lease is taking far too long, both in Hilo but across the board. So we're looking at that systematically. The interim lease is in place, and I think we're in a position now to execute against that interim lease as we try to push on the permanent lease, which is now about 9 months delayed. So we're staying on top of it.
Thank you.
Senator Hoeven.
Thank you, Mr. Chairman. Secretary McDonough, it's good to see you again.
Nice to see you.
For all that work you did as Chief of Staff, and good to see you in your new role. Congratulations on that.
Thank you.
Appreciate the opportunity to work with you again. Thanks for being here today to both of you. One of the things that I've been working on for a long time is, and we've included language in a number of the bills that we passed, the VA Missions Act and a number of the other veterans bills that we passed. If a nursing home takes Medicaid or Medicare reimbursement, they have a set of standards and inspections that they have to meet. But if they take VA reimbursement, then they have additional standards they have to meet. So they end up with multiple inspections and additional regulations. As a result, only about 20% of the nursing homes in the country take VA reimbursement for long-term care. That makes a huge difference to our veterans because qualifying veterans can actually draw on the VA benefit without having to expend all their assets. Unlike Medicaid, for example, where they would have to first dissipate their assets down to a standard test and varies a little bit by state. So for qualifying veterans, this is a big deal. Now, about 20% of the nursing homes do take VA care or VA reimbursement, but a lot don't for that reason. And so we're trying to work with you and with labor and with HHS to get these veteran care agreements simplified so that these nursing homes will take veterans with VA reimbursement because of like I say, the asset test. And so I would ask for your help, and we've just hit a number of different challenges. Sometimes the VA tells us, well, those additional requirements and those additional inspections we're just trying to take care of veterans and we're just trying to protect the veterans. Well, I mean, that almost kind of makes the assumption that HHS and states aren't taking care of other seniors. So, I mean, that doesn't really seem to fly. It really is a red tape problem. And so if we could work with you to streamline that so that if a nursing home meets all the requirements for Medicare or Medicaid, then they shouldn't have additional set of requirements for VA reimbursement. So that's the issue, and I would ask for your help on it.
Thank you, Senator. I confess that it's. I know you've been working with us. I'm not deep on this. I will just say the following, which is that our experience during the pandemic is that our clinicians far exceeded performance on reduction of COVID infection in our facilities as related to other facilities, both state-run facilities, state-run VA veterans facilities, and privately run facilities. So I think there's a lot of work that we've done in this space, but I'd be more than happy to take this and commit to work with you on it.
Yeah, and the key is access, because you may have loved ones that have to travel a distance if they can't get their loved one in a nursing home close.
Yeah.
And this is not just a North Dakota problem. This is a nationwide, that stat I have cited as a nationwide stat. Hyperbaric oxygen therapy, HBOT. The veterans really feel that this is important to them, particularly for PTS. And we've got a pilot program going. There's a number of locations, including the VA Center in Fargo, which is a high-quality, outstanding center. Serves a lot of North Dakota, but a lot of Minnesota, too. But are you committed to making sure that our veterans can get access to HBOT?
Yeah, well, we're running that pilot currently. I just asked for an update on it yesterday. It runs, as you know, through this fiscal year. So we're absolutely committed to making sure that we run this through. We get a high-quality review of this, and then, as we've assured you, we will make the decisions based on that. So I'll be more than happy to do that and stay in close touch with you.
Yeah, we'd like to work with you on that, too. We've talked to so many veterans that really, really swear by it. And so I think this is going to be something, and not just veterans, as you know, for concussions and other things as well. All-star football players like John Bozeman and others, sometimes think it has been very beneficial to them. I'm sure you've seen the Joe Namath commercials, and he talks about it. Last thing I'll bring up.
The secretary played.
Oh, is that right?
Yeah.
Yes, I did.
He was
Where
in the
did you?
He was in
Where?
the secondary. Yeah.
I played at
Minnesota somewhere?
St. John's University.
Oh, you're a Johnny. Was that back when they had the fabulous teams? They had a long string of championships.
Yep, they had a bad defensive back in me, but very good teams.
Good for you. Fantastic. Last question, I'll be quick. I'm sorry, Mr. Chairman, is just ask for your help at the rural. We have the Rural Initiative Cemeteries. Great program.
Yes.
Huge kudos to you. We have one now in eastern North Dakota. Just ask for your continued commitment as we add, really important things like restrooms and storage and wind walls and things like that. Fabulous initiative in rural America, and I would just ask your strong support for it.
Yep. You got it.
Yep. Thank you. Thank you, Mr. Chairman.
Senator Tester.
Thank you, Mr. Chairman. A couple of housekeeping things. First of all, I want to thank Secretary McDonough for bringing up John Warner. John Warner gave me the best advice I've had since I got here, and I've seen this advice play out several times. His advice was, "Don't stay here too long, kid," which is good advice. And then the other thing, Mr. Chairman, I just want to point out that you have possibly the best staff director of any of the appropriations committees in Michelle Dominguez. She is absolutely the most competent staff member on the appropriations committee that I've ever been affiliated with, and she used to work for me. So, Mr. Secretary, the VHA brought on nearly 8,000 employees under the temporary emergency funding of COVID-19. What is your plan to keep those folks on board when the ARP money runs out?
Well, we're letting the demand for services inform that. We have a particular set of demands, and I know this is particularly important to you, around mental health. So our first and biggest effort is to retain the excellent clinicians that we have, even as we approach a series of expected retirements. We're right in the middle of the annual employee survey at the moment. We'll get data from that. Will give us a sense of what to expect coming in the new year. But the first and biggest challenge for us is to retain the people that we have. And then next is to make sure that we're not just out competing with other healthcare systems, but that we're adding to the available clinicians, and this is where our education component and our residency programs become so important to us. So that's why we have the funding that we have requested in the budget, and we'll continue to work with you guys on precisely that.
Thank you. Community care was brought up previously, but I just want to approach this from a little different angle. There's been a lot of talk about the wait time to see a doctor within the VA, and correct me if I'm wrong, but I understand you're meeting the guidelines for wait time. Is that correct?
We are, yes.
Okay. Are you able to track the wait times in the private sector?
We're looking at that now to make sure that we have a good handle on this. Come a year from now, we have to make some decisions about our access standards. That's what the law requires us to do. I've implemented and started a process over the course of the last 6 weeks or so where we get the data to help us inform the decision making that we have to make in consultation with you for a year from now. Among the data I'm asking for is veteran satisfaction, health outcomes, wait times, and commensurate wait times for care in the community.
I think that's really, really important because the fact is that wait times have been an issue. It's, by the way, why we have community care to begin with. And if we're not addressing that issue through community care, then we need to go back and address it. Speaking of mental health, I was surprised in this year's budget that the VA is treating 6,000 fewer vets via inpatient mental health care in 22 than it did in 21. Is that because of telehealth, or is there another reason here?
I think it's principally due to telehealth, but John, am I missing anything on this?
I do not know the answer to that.
Okay, well, let me take that specifically, Chairman, but I think that's due to telehealth because, frankly, we see our demand is up across the board.
Appreciate that, and I agree. Now I want to talk about something that's near and dear to both our hearts, and that's toxic exposure, and in a bill that Senator Bozeman is very familiar with, as well as myself and other folks that are on the VA committee. The budget supports about $7 million in new spending on toxic exposure research to focus on collaboration between the VA, DOD, and the national academies and other stakeholders. My question is, do you think the VA should be the lead federal agency on veteran toxic exposure research?
I do believe we should be, and I think that we are.
And do you feel that increase of $7 million establishes the VA as a leader on this research?
I think it does, but I also think, Chairman, as you're aware, we've also set up a process whereby we are getting the benefit of all the other science agencies, DOD, Department of Labor, HHS, and their attendant offices and capabilities on a very regular basis. In addition to the National Academy of Science, and my commitment to you all is to not only to continue to get that science, but to report to you on a quarterly basis what that science is telling us, including about whether we're in a position to connect other conditions to service in Southwest Asia.
I know that community care was talked about earlier and the amount of money that's being spent on community care, and in some aspects that's simply not sustainable, especially as it applies to emergency room treatment. I want to give you an example, if I might, Mr. Chairman, of a story that was relayed to me just last week by a doctor that works for the VA and is very proud to work for the VA. And a patient came in, I believe he had kidney stones, and he got to see him at about 4:30. And, of course, the day ran out at 5. And the advice that was given to him by his superiors was just send him to the private sector. The guy wanted to be treated by the VA. And the easy way to do it, and maybe this is the problem, the easy way to do it was just get them to the private sector. I know you're concerned about this, and I appreciate your concern, and I just think that we need to be wise about how we utilize the private sector. It's the veteran's choice. It's not the VA's choice. Thank you.
Yeah, I would just say one thing about that is, two things about that. One, what the clinicians tell me is that to refer a vet to the community takes, in our current electronic system, 2 clicks. To refer somebody back into care in the system is something like 18 to 20 clicks. That doesn't seem right to me. That suggests, I think, as Senator Schatz was asking, a kind of an institutional direction. So I've asked us to look at that. The second is our facility in Ann Arbor is going through and running a pilot about access to emergency care, including access to mental health services. And this is anecdotal. This is why we're out getting some kind of statistically significant information from our vets. But the anecdote there was our hospital administrator told me is that when she invited vets back into care in the system, they all asked, three of them said to her, I'm grateful that you asked, and I was wondered why you pushed me into the community in the first instance. And so I don't know that anecdote adds up to something statistically significant, but I want to make sure that we're giving the vet and the clinician the opportunity to make the best, what the statute requires, the best possible outcome for the vet deciding this. That requires us meeting our wait times, but it also requires us making sure that we don't tilt the record.
Senator Baldwin.
Thank you, Mr. Chairman, and welcome, Secretary McDonough. I know that when we spoke earlier this year, that we talked a bit about bipartisan legislation that I had sponsored, the Jason Simkoski Memorial and Promise Act.
Jason's Law.
Jason's Law. And it was signed into law in 2016. And the law has been effective in strengthening oversight of the VA's opioid prescribing practices and providing safer care for our veterans. So I thank you for the department's support of Jason's Law in the fiscal year 2022 budget. The progress that Jason's Law is making to improve the care of veterans is I think, really quite remarkable. And I remain committed to working with you to ensure delivery of the highest quality of care to our nation's veterans. But I also want to thank you for your commitment to meet with the Simkoski family to discuss implementation of the law that is named after their son, Jason. Can you give me any updates today on the VA's effort to reduce or right-size the prescribing of opioids, in addition to the latest VA-wide statistics on the rate of opioid and benzodiazepine prescribing?
I don't have those. I would be more than happy to provide those data to you when we leave here. I don't have those at my fingertips here. I believe informed both by the tumultuous experience, traumatic experience at Toma, as well as a national epidemic on substance use disorder. Our programming continues, as you suggest, to make good progress. This includes very aggressive record keeping about prescription practices, and that includes us working very hard to harmonize our records for prescribing in the community as well as prescribing in the system. So I think we're making good progress there. But the fact is that substance use disorder remains an epidemic in the country, and so we'll stay on top of this.
Yeah, on that note, the COVID-19 pandemic has, I think, increased the severity of our opioid epidemic.
Yeah.
And I'm wondering if there are any particular departmental programs to address this within the veterans population. Pandemic-related adverse mental health and opioid abuse.
Well, there's been reporting on incidences of increased prescription of opioids for pain treatment and long COVID. And overall, there's been reports in across the health system, not the VA system, but across the U.S. health system, of prescription of opioids for pain management in the context of COVID. In reaction to those stories, we went back in VHA to look at prescribing practices. We don't see that currently in our system. We have looked at that and we'll stay on top of that for the obvious reasons. But it also goes to the point that I think the budget request also goes to, which is the research capacity that you enable through the budget at VA is incredibly important. Nobody is doing as much research right now on long COVID as we are. That's facilitated by how we aggregate data, and that will be improved even greater when we get this electronic health record on track. But it also speaks to the fact that that's a fundamental capacity we need in-house and that we need to make sure that we sustain over time. And we are using that expressly on substance use disorder and watching it very closely. And we'll obviously, we know of your personal interest in this, and we'll stay in close touch with you on it.
Thank you very much, Mr. Secretary. I have run out of time. I will submit 2 additional questions for the record, one pertaining to K2 veterans and exposures, and the other dealing with partnerships between the VA and our county or tribal veterans service officers to make veterans in local communities aware of the full array of services that they might be eligible for.
I just, at the risk of going over, we have the annual Tribal Nations Summit at the White House in this fall. This is one of the things that we're trying to develop more robustly in anticipation of that. We are seeing really useful collaboration between our national facilities and local and community facilities and IHS facilities that builds on some authorities you have given us. That might be something that we should follow up with.
Great. Thank you.
Mr. Secretary, I look forward to hearing more on that front. Actually, I think Senator Baldwin and I share an interest in, and that's a very complicated, coordinated care model that oftentimes our tribal veterans have to utilize. I want to ask you a question about compensation and pension exams. Under the previous administration, the department indicated that it planned to contract out nearly all of the compensation and pension medical exams. And despite a number of VSOs, many senators raising concerns, the VA continues to largely privatize this component of its mission and is requesting funding for more staff to oversee those contracts. What's the financial basis, first off, for contracting out, and how does the cost of providing this service internally compare with providing it through these contracts?
Yeah, so first and foremost, we have a significant backlog at the moment. So I think part of the funding that you see reflected in the budget is our commitment to get that backlog down. That backlog springs from the pandemic. There was about a 2-month period during which we did no exams out of deference to the safety and health of our vets. That number is now at about 180,000. It's down from about 220,000. So I don't have the dollar for dollar comparison, but I will get that for you and submit that. But I think you are right that we continue to rely a great deal on contracted CMP exams, but we've cranked up volume on 2 other ways to administer the exams. One is in the system. This is out of a collaboration among Dr. Stone at VHA and Tom Murphy at VBA, where VHA is now providing additional in-system CMP exams. That does come at expense of other or at the cost of other services that VHA is providing. So we're looking closely at that and tracking that closely to make sure that that doesn't tip in the wrong direction. And then we're providing CMP exams through video telehealth, video and telehealth. And so that also increases demand on our in-house practitioners. But I think it's really important that we that we get that backlog down. So that's what's reflected in the budget. As to the specific dollar for dollar comparison, let us make that, and we'll get that back to you. Unless you have that off the top of your head. Okay.
Great. No, I appreciate that. We've talked a little bit about the unique challenges that rural veterans face, but access to care in person or via telehealth. It's just hard recruiting and retaining primary care and specialty providers. This budget requests $307 million to support rural health initiatives. It's a modest increase over prior years, especially in comparison to the overall budget growth. But can you talk to us just how is VA developing and implementing enterprise-wide initiatives to make sure that we're serving veterans in those rural areas adequately?
Yeah, it's a great question. I mean, we have our Office of Rural Health, which is kind of the principal place where we're innovating on policy there. I'll give you a couple of examples that I think are useful. And let me just correct the record on one thing. I looked at my notes after my answer. What it says here is as of June 21, the rating claims pending of over 125 days is 190,000, not 180,000. So I misspoke there. What we find is a couple of different things about our primary care physicians in rural areas. One is obviously distances traveled. We have a relatively small number of practitioners covering a lot of different CBOCs over, as you know very well, over a wide expanse. We're trying to address that by increasing the number of practitioners. You have some isolation, professional isolation, where it may be a very vibrant, I know this doesn't happen with my colleagues who work with me, but sometimes you work with a colleague who happens to be, or colleagues who happen to be very smart, very engaging, gives you opportunities to grow. When you're on the road all the time, you get less of that. So we're trying to use, for example, telehealth opportunities, and video connect opportunities to increase that interaction. We're also using available authorities through that same Office of Rural Health to increase travel options for those practitioners so they're getting to additional career development, specialty development options. Lastly, we're increasing the use of educational partnerships to again enhance career building opportunities. So none of these alone adds up to everything we need, but each innovation in that space I think is important, and will continue. And this budget does continue to invest in our ability to do that.
Yeah, I think all of us up here would agree that that's incredibly important. And I'm running short on time, but I'll just raise one more issue that's related to that, which is the VA's Highly Rural Transportation Grant Program. In FY21, it was funded at less than $3 million. Our discretionary budget this year is $113 billion. I just think this is a place where we need to look to make sure we're actually meeting demand, and that number in FY22 as it actually gets implemented, I think is a place we need to look at beefing things up. And with that, turn back to the ranking member.
Well, thank you, Mr. Chairman. And I just want to touch base on the electronic health record modernization program.
Yeah.
It's such a huge issue, big expense, and just a gigantic project that's so very important. I know the budget requests $2.7 billion fiscal year 22. I understand the review will reshape the program significantly in every facet, and again, its financial needs. House is going to begin marking up their version of this bill on Friday, without the benefits of the results of the strategic review. Right. So I know you can't go into it, in the sense that it's not done, but can you just kind of tell us how it's going and when we can expect the information to come out?
Yeah. We
deployments.
don't anticipate changing the budget request. The shape of it may change, but the numbers themselves will not change as a result. I'm tempted to try to say it will be reduced over time, but I'm not going to say that.
Sure.
But hopefully we can do that. We have identified that we believe that the technology basically is sound. We think that we probably undervalued and underinvested in training and support to our team in the field, and as they're going through the change of this process. We also, I think, have identified some structural inefficiencies in headquarters and how we govern the project. So that we'll be changing that too. We have not. The big question is when we go to a next site to deploy the system in a next site. Under previous course and speed, we'd be going next to Columbus, Ohio, in fairly short order. That decision, I've not yet made that, but that's a threshold decision. I anticipate making all these decisions and talking to you about the full shape of this by the middle of next week, by the 30th. We owe you some answers, as you laid out in your opening statement, pursuant to statute from last year. We're going to live up to that and make sure that we get you the information you need immediately on the 30th, but we'll maintain a very fluid conversation with you on this. Last thing I'd just say is one of the reasons I really want our deputy, who's still pending here, confirmed, is he's the person who will be overseeing this, given both the traditional role of the deputy in our department and the statutory requirements that he personally oversee the budget. I'd love to get him down there soon so he and I can spend some time over the weekend making sure that we're on the same page before we submit all this paperwork to you on Wednesday.
Good. We appreciate that. And again, the committee's very, very supportive of the project and understands how important it is. I think I can speak for all of us. And so, like I said, all of this is an effort to help you, push forward, and we certainly will do that any way we can. So, thank you, Mr. Chairman.
No, thank you, and thanks to Secretary McDonough and Mr. Rychalski and all of our senators for participating in today's hearing. I think we all look forward to working together to make sure we provide the resources for the VA to be able to do its job and do its job at the best possible quality. Finally, I'll keep the hearing record open for a week. Any committee members who would like to submit written questions for the record should do so by 5:00 p.m. Wednesday, June the 30th. And we very much appreciate the department responding to them in a reasonable period of time. And with that, we stand adjourned.
Thank you very much.